Good afternoon from the annual meeting in San Diego. We're pleased to have today with us Dr. Russell Swan. Thanks, Russell, for being with us today.
Thanks so much. Quite an honor.
Russell, I know you had a great presentation at this meeting about a novel technology for affecting intraocular pressure. Tell us a little bit about that and how does it work?
Yeah, so our study was designed around a pair of goggles, a multi-pressure dial that allows us to individually control pressure by applying negative pressure to the anterior sort of orbit and thus influence intraocular pressure. So the study was a study of 65 patients, 130 eyes, and what we did was we had one eye serve as a control that didn't receive any pressure, and the other eye incrementally received a negative 25% IOP reduction, negative 50 and negative 75% dialed in, and that was for 20-minute increments. And what we found is in a normal population, we were able to dial down the intraocular pressure safely from about 16.5 down to 13, down to 11, and down to 9, which is really, really exciting. And importantly, we didn't see any rebound hypertension immediately after removal, and we didn't see any adverse side effects in terms of effect on visual field, OCT, best corrected visual acuity. So really, really exciting.
That's a really, really cool device. And so if I understand this correctly, it's a pair of goggles that creates a negative pressure environment inside the sealed goggle, right?
Yeah. Yep.
And what you evaluated, you kept one side, whether it was the right or the left side, sort of normotensive or atmospheric pressure, and then the other side was negative pressure, and you compared contralaterally, right?
Exactly, yep. So each patient served as their own control, which was nice, and exactly the negative pressure was just applied in a regulated, controlled fashion, and it was randomized to either eye. But yeah, it was really fantastic.
So share with us some of your results. What was the outcome of negative pressure, of applying negative pressure to the one eye? I know you mentioned that you were able to achieve a substantial pressure reduction, but I understand that also you measured some time point later to see if there would be a change in pressure, sort of a rebound pressure. What did you find there?
Yeah, so for the 25, again, baseline pressures were about at 16.5, which is in a normotensive patient what we would kind of expect, and we were able to dial it down at 25% reduction to about 13. At 50% reduction went down to about 11, and at a 75% reduction just over 9. And as you mentioned, importantly, never saw immediately after removal of the goggles, 1 week after removal of the goggles, we didn't see a rebound. We kind of wondered, would we see a rebound immediately after taking them off? And taking a measurement right after, didn't see that at all, which is super exciting.
That is a really cool finding, Russell. I'm wondering if you can sort of project, where do you see this type of technology fitting into the existing IOP lowering space? Is this something that people would wear all day long, or a certain time period, a certain time interval during the day? How does this fit in?
Yeah, great question. Certainly they could be worn all day, and you could build a prescription into them and allow them. Where I see it fitting in initially is in the nocturnal space. So we know on average people have higher pressures at night. We know our traditional treatments that we have right now in terms of most drop therapies don't work as well at night. So if we can be able to safely treat those patients in a titratable fashion in a safe way and blunt that nocturnal phase, I think we can really do patients a favor and do it in a really safe way. It's a novel treatment. It's non-pharmacological, it's non-surgical, it's non-laser, and it's titratable. So to be able to do that and to do it in a potentially normotensive patient, which we don't have great options that have traditionally really high risk, it's really exciting.
This is also, it seems like a really great way to improve adherence in people who have trouble with instilling eye drops. We've had many experts on the program who have attested to things like arthritis and dementia and other sort of day-to-day barriers that prevent people from physically getting that medicated eye drop into their eye when it's needed. And so maybe this is a way for people who can't take eye drops for one reason or another to still get an IOP lowering effect.
Absolutely. Really nice point. And the other nice thing about a wearable treatment device is you can also track whether someone's wearing it. So you can track and see how much of the time the pump can track, how much of the time was someone actually, when the pump was activated, were they able to maintain suction, or how often were they doing it? So you don't want to be a big brother necessarily, but you also can use that information to help drive, okay, well, why is it that, certain evenings you're having trouble wearing it potentially or other things, and really be able to help partner with your patient and getting them great care.
Well, I'm wondering, you spoke a little bit, Russell, about wearing it at nighttime as a potential treatment paradigm. Do you think that having the eyelids closed during sleep versus open during the time when you tested the device. Do you think that would have an impact on the final outcome?
Yeah, great question. We don't expect it to. I like to say it's just physics. So if we're applying pressure to the anterior sort of periocular space, our expectation and belief is that that's going to not only it would not be affected by the eyelids being open or closed. We're starting to look at a lot of other parameters, looking at blood flow, looking at OCT, OCTA, and what we know is that there's influence in all the way back to the posterior pole that we can document by a sort of other areas. So it's really exciting to think about the possibilities here and realize that probably even with the eyes closed, we're not going to see any issues.
I wonder, Russell, if you ran into any side effects or any complications during your trial from this negative pressure environment. Did you see anything that you didn't expect?
Yeah, so our safety endpoints were best corrected, visual acuity, visual field, RNFL, all of those were okay. The one adverse effect we did of the 65 patients, one patient did develop a small epithelial defect, felt to be strictly related to the IOP measuring technique, and that resolved within 24 hours without complication. But all 65 patients tolerated the device wear for the 60 minutes. Ultimately, the question will be, okay, when that's extended, and is that 8-hour treatment or 12-hour treatment, will you get the same tolerability? And those, I think, are questions that will be bore out in future studies that we continue to do.
Right on. It's such an interesting and novel way to approach intraocular pressure. I'm wondering, how did you come up with this idea? Where did it stem from?
Yeah, well, so I certainly don't get credit for the idea. My partner, who is a very innovative mind, John Birdall, this is really his baby, and he kind of came up. He tells the story of scuba diving, and wondering, well, gosh, I have all of this atmospheric pressure when I'm underwater. Why isn't that I don't just immediately get glaucoma? Because I have an extra, maybe 1,000, 1,500 millimeters of mercury pounding on my optic nerve. And he got the idea of, there's probably something to do with pressure differentials. And so what if we could just lift off some of the atmospheric pressure to basically decrease the pressure in sort of a novel physics sort of way, as opposed to a medication-driven way, a surgical-driven way. So,
it's an interesting corollary that there's been quite a bit of study on space travel and the sort of zero gravity environment of space and how that has effect on the optic nerve. I wonder if this device may sort of allow a simulation in that kind of environment.
Yeah. So going back to the very beginning of this project, actually one of the initial funding sources for this was actually NASA. So they gave a seed grant to Dr. Birdall to help start this project. And you're absolutely right. If the thought process for a lot of, now this has changed from VIIP to SANS to all these different things for space-associated neuro-ophthalmologic syndrome, but you have loss of gravitational pull, increasing CSF pressure, and particularly around the eye, and you get a swollen optic nerve, you get a hyperopic shift, choroidal folds. And I do think that there's a belief that you could potentially apply the opposite, positive pressure, and balance out the what we would term the, translaminar pressure gradient, and maybe be able to reverse that or blunt that. And so I think that that's an exciting thing. It is easier to get a pair of goggles to stay on that you're applying negative suction to, because they'll hold on to the eye. If you're trying to apply positive pressure, it's a little different world. But I think that that'll also be something that's super exciting. The population base for astronauts versus glaucoma is a little different. So from a commercial standpoint, glaucoma is a little better target, but it is exciting. So
this is a great technology. I'm so glad you're able to share your expertise, Russell. Thank you so much for being here, and thank you to our live audience for your support as well.
Absolute pleasure. Have a great day.